So we wanted to look at biatrial versus left atrial lesions because it's controversial right now. Historically, we've been taught that you need biatrial lesions. You really need a very complete lesion set. What stimulated this paper was a prospective randomized trial from CTSNet indicating that patients with just pulmonary vein isolation and mitral valve surgery did as well as did patients with biatrial lesions. And we had always had equipoise, and so we had some patients with biatrial, some with left atrial, and so we thought it'd be a good opportunity to do a study with propensity matching and advanced statistical analysis. So the findings were somewhat expected and somewhat unexpected. What we found before matching was that there was really not much difference. There were more pacemakers in the biatrial group, and a recent meta-analysis had indicated that if you do biatrial lesions, you're more likely to get the need for a permanent pacemaker after surgery. After we matched, we didn't really find very much different. We didn't find a lot higher freedom from atrial fib with or without antiarrhythmics in the biatrial group. So what we're concluding from that is that if you fix the mitral valve, that gets rid of the volume and the pressure overload in the left atrium, that gets you a good ways. Then if you do this box lesion with a mitral annular lesion, that takes you another ways. And then if you add the right atrial lesions, it might make a little difference, but at least in our study, statistically significant, it wasn't an important difference. Based on what we found, I think the take-home message for most people that are practicing is going to be, if you're doing mitral valve surgery, add the left atrial lesion set for the AFib ablation. In particular with cryoprobes that we now use, it's quick and it's easy, and you can get transmural lesions, and it's really not adding much time and certainly not risk to the patient. We are doing far less right atrial lesions and creating a biatrial lesion. For reoperations, for patients who are elderly, we had already stopped doing that, and patients with just paroxysmal atrial fibrillation, we weren't sure that it added much at all. The future directions will have to include, ideally, a prospective randomized trial, and we're thinking about doing that at Northwestern, if not as a single center, then having some of our colleagues involved in doing a multi-center trial.